Okay, good evening, everyone. Thank you for joining us once more, some of you maybe for the first time, to the public forum of the Goodman Cancer Research Center on cancer research. This series has a special location. It's essentially about hope. Hope because that's the essence of research, as a matter of fact, seeking solutions to complex problems like cancer. And in my view, the best, possibly the only rational approach there is to this terrible disease. I'm Tom Duchesne. I'm a professor and researcher here at the Goodman Cancer Research Center. But our forum are actually usually articulated around great people in Montreal and surroundings, not only at the GCRC, but in sister institutes and partner institutes, collaborating institutes around. Tonight, we have speakers from the Glen site, the MUHC Glen site. We have speakers from the Genome Center nearby. And we also have researchers from the Goodman Cancer Research Center, of course. We also have wonderful testimonies, which usually end up showing the human face to the science and to the treatment. And we're really grateful that Hélène is here tonight for this important mission. Tonight, the topic is renal cancer. And you'll see that some of the topics, some of the themes that we crisscross through tonight are common with several of the other ones you heard before, or might directly be related to things you heard about other types of cancer as well. Things like immunotherapy, for example, precision medicine. These are themes that define cancer treatment in 2019 that were actually not up at the top of the list in 2015, if any, completely under the radar. So it's just to tell you how things change fast. And very often they change faster at the bench in the lab than they do change in the clinic. So it's really important to stay abreast of the latest findings because it actually ends up making a big difference. And that's like precisely the case with precision medicine, personalized medicine. It makes a difference in treatment. And it empowers patients also with more than just being at the receiving end, but more through the thought process. And we've all had family members. Some of you actually may be survivors of renal cancer. There's a major difference as to our cancer being a black box versus actually understanding a bit more and being part of the decision process. This is going to be another important theme tonight. So welcome. The overall presentation tonight will be first a presentation by Simon Tanguay from the MUHC. He's a professor in the Department of Surgery, a division of urology, and he's head of the division of urology and Department of Surgery at McGill. Yasser Riyadza Hosseini. He's assistant professor at the Department of Human Genetics here at the Human Genome Center. It's called Genome Quebec Innovation Center, precisely. He's also part of Human Genetics. And finally, we'll hear a talk by Arnim Pazzi, a friend and colleague of mine. We're neighbors. And Arnim works on the molecular aspects, the genes involved in certain subtypes of renal cancer. So for those of you who want to sink their teeth deeper into the science and hear a bit more of those complex gene names, but also in the same time catching what might be a future avenue of treatment, this will be Arnim's talk. Finally, and not least, will be a testimony by Hélène Veilleux. Hélène Veilleux is, I've been fighting this disease for a long time, but she fights it not only for herself. She's courageous, and just coming here tonight is actually a sign of that courage and that generosity. But she's also engaged as an advocate for patients. And you'll hear her story, but you also hear a little bit of information that may be helpful for you or some of your loved ones that will be actually brought tonight by Kidney Cancer Canada. And we have also actually representatives of this foundation tonight here present. So we have a lot of information and different aspects of the problem and also of the solution tonight. Finally, as it's always the case, all the speakers, and Hélène tonight actually agreed to be part of that, will join us at the table And during the evening, at all moments, you have this white card, I think, and a pen with you. You can write any sort of questions you have in mind. And we have volunteers at the very end that will actually circulate and catch those questions of yours. And the full panel will answer your questions. So the idea is to take questions that may appeal to the broad audience. I would kind of encourage you to wrap it so that it's appealing to everyone. It shouldn't be a specific patient type. Please try to make it a bit more general. I sift through them. If there's a case, a more precise case for a patient, usually what I do is I keep them aside, and you're free to come down later and discuss with the panelists after, after the forum itself. Okay? We're clear? It's good? Thanks for being here. Yes, a question? Okay, so what I'll try to do is speak closer to my microphone. How's that? We can also increase the volume of the microphone. Nope, don't touch it. Okay, we have whizzes around. We shouldn't bypass the technical expertise of these guys. Okay, all right, I stand corrected. Our first presentation tonight is by Simon Tanguay. Simon is a professor at UHC, and he's also head of the Division of Urology. And he's going to tell us about the outcome prediction and advance and treatment for renal cancer carcinoma. Simon, I will just help you out with the first talk changes here, and you should be good to go.
Thank you very much. Good evening, everybody. Great pleasure to be here. So what I prepare is, because I assume the audience is broad in the knowledge and regarding this disease, so I really give you a very superficial but broad a view on what kidney cancer is and how we treat kidney cancer. And obviously at the end, we'll be happy to take more specific questions if it triggers some interest in specific items. Yep. So the kidneys, first of all, what are our kidneys? Obviously, we all know we have two kidneys. They're obviously very important organs. You can see both kidneys here, and on the top we have what's called the adrenal gland. They're located in our back. They're important because they're the one that filters our blood. They're the one who cleans our blood from everything that should be, removed throughout. And they also have a role in the management of the blood pressure. Also, they secrete some hormone responsible for red blood cell production. So when our kidney function decrease, we can have problem associated with that. And basically, kidneys are important. They're essential to life, actually. If your kidney fail or if you lose both kidneys, which can happen, that's when you end up needing dialysis to support yourself. The kidneys are also located in our back, but relatively high, because sometimes we see patients that have a large kidney tumor and they say, how come we cannot feel them? Sometimes people are very skinny and we don't feel these tumors. It's because the kidneys are protected in part by our rib cage in the back, and really sometimes the tumor is sitting very high, and unless you have a very large tumor, very often we cannot feel that. And sometimes people say, well, I've seen my doctor, they examine me every year and they did not pick this up. And actually it's difficult to pick a kidney tumor just by physical examination. Kidney cancer represents a frequent cancer. It's about the 5th or 6th cancer in men. It represents a bit less frequent in women. So there's a discrepancy. It's a cancer that we see more commonly in men than in women. For urologists like me, cancer is actually a large part of our practice. If you look at that list, you can see prostate cancer, which is the most common cancer in men, bladder cancer, that's very common and rising also, and kidney cancer. So for us, in the top 5 or 6 cancer, 3 of them are urologic cancer. So it's a large part of our practice that's dedicated to the care of cancer patients. Now, the first thing that's important to understand is that kidney cancer are not all the same. There's variants of kidney cancer like cars. These are Audis. There's many types of Audis. You can get different subtypes of them, and they all have their particularity that make them good or less good. And kidney cancer is the same thing. We we have different, we call them histologic subtypes, meaning that when the pathologist look under the microscope, he's going to tell you which type of kidney cancer you have. And this may or may not have implication for you, but some of them behave better than others. Some of them will also have a big impact on the type of treatment we can offer you after, if you need more treatment. So the type of kidney cancer is certainly a very important information. You'll hear later about all of these gene pathways that lead to the development of that. We know that at the base there are some mutations that happen in our genes, sometimes mutation that you're born with, but most commonly mutation that happen in your kidney cells that develop kidney cancer after. And for the different type, they will be very different, these type of mutation. The most common is what we call clear cell carcinoma or conventional renal cell carcinoma. And then you have papillary and chromophobe, and then you have very rare subtypes. So these are the three most common type of kidney cancer that we see. In Canada, what does kidney cancer represent? About over 6,000 patients every year that are diagnosed with kidney cancer. One of the particularity of kidney cancer is that every year the number increases, and this has been for the last 20 years. The exact explanation is not truly known. There are probably some environmental factors that play in this, but every year about 2-3% increase in the number of kidney cancer that we see in Canada. As I mentioned before, it represents 3% of all cancer, most common in the 60s and 70s. But this dogma of the 60s and 70s, I think, is slowly going away, because truly we see them in every age group. We see them in the early 20s, and we see them in the 80s. In our practice, we see, unfortunately, people of every age facing this disease. I mentioned before, more common in men than in women. We'll see later in the next presentation the impact that this can have on the behavior of these cancer. Now, the good thing is more and more kidney cancer are detected early. About 60 to 70 are localized at the time of the diagnosis, meaning that when we find them, they're still only involving the kidney. They're not spread to any organ. This comes in part because we have much better access to imaging of the kidney or the abdomen. People have an ultrasound because they think they have a gallbladder stone or they have abdominal pain, and they get a scan or an ultrasound, and that's how we pick these kidney cancer. And very often we pick them extremely small, 1-2 centimeter, and we'll see later that the earlier we pick them, the more likely that we can get rid of it forever, and it plays in your favor. There's still about 15 to 20% that at the time of the diagnosis, the cancer will be spread to other organs, and this will create some challenges. How they present, as I mentioned, today probably 60-70% are incidental finding. We don't look for them, but we find them looking for other problem. If you have symptoms from kidney cancer, the most common one would be blood in the urine. You see some ads on TV from Bladder Cancer Canada. It's a patient organization that tell you that if you have red urine, it's not normal, seek attention. They advocate for the diagnosis of bladder cancer because that's how bladder cancer present also. But kidney cancer is the same thing. And very often we see patients that said, well, I bled once, my urine were red for one day and then it disappeared, so I figure it's okay. Sometimes it's the first and only sign that people will have, and it's very important to react to this and to seek attention. People can have pain. People can feel a mass. Sometimes people will feel the mass and come to see us. Then sometimes it's other general signs, like fatigue, weight loss, development of anemia, other problem that will trigger your family doctor to do some tests and try to figure out what's going on, and then we find the kidney tumor. When you see the urologist, there's two things that will be discussed with you, and these are the two terms that come all the time. It's the stage and the grade. The stage is the local extent of the cancer. How big is that tumor? Has it moved to other organ? This is the stage. There's two types of stage that we use. One is the clinical stage. First time you come to my office, we look at the scan, and I tell you what's your clinical stage. It's based on the finding of the X-ray. And then if we do surgery later on, you have what's called a pathological stage. Pathological stage comes from the pathologist's report. When they look under the microscope and they tell me the true extent of the tumor, this is the pathological stage. This one is the more meaningful and power in predicting what the future holds for you. But they're both very important. The grade is the aggressivity level. Okay, in kidney cancer, we use a system that goes from 1 to 4. 1 and 2 are what we call the low-grade cancer, and 3 and 4 are the high-grade cancer. So these are the two terms that you will see coming all the time. We use a system also that's called the TNM system. It's true for kidney cancer, but it's also true for every cancer that exists. T represents the tumor. How big is that tumor? How extensive it is. N represents lymph node. Are your lymph nodes locally or elsewhere affected by the cancer? And M represents metastasis. Has this cancer moved to other organ, to your lung, to your liver, to your bone? So this is the TNM system. There's also another system that people use very often, is the stage 1 to 4. I think this is often what people refer to, and it's a variant that we use in the TNM system that represent the same thing. The smaller the number, the better it is. And basically in kidney cancer, if you look at the extent of the cancer in the kidney and regionally, you have these stage, and obviously the lower the number, the better the outcome is. I always warn people to be careful with statistics, because it's not because your statistics look great that you're off the hook and it'll be fine. It's more likely to be. And it's not because the statistics don't look good for you that you'll run into trouble. Statistics are based on a large group of patients, and you're a unique one. You're 100% of your own statistics. And sometimes we need other tools to be more precise in predicting what can happen to you. And you'll hear a bit more later this evening about these tools. And basically, to try to refine our finding, we do some imaging, we do ultrasound, we do scan, we do MRI, we look at your bones. There's a number of tests that can be done to better establish the true extent of this disease. Based on that, that's where the urologist or your surgeon will make recommendation on what should be done. The stage of diagnosis, you can see for different cancer, the stage, the blue is stage 1, the lower one, and the orange is the stage 4. So as I mentioned before, majority, thank God, of our patients present with the lower stage disease. Now, if you have what's called a localized disease, a disease that's only into your kidney, there's a number of treatment that we can offer you. The first one, funny enough, is do nothing. And when we discuss doing nothing, people say, it's a bit crazy. How do you tell me I have cancer, now we do nothing? So we know that kidney cancer, when they're picked very small, and when you do a biopsy that tell you it's not an aggressive form of cancer, and some of the variants that I showed you before are more favorable, some of them we can decide just to watch. Classically, we'll do that when patients have other medical issues, when the risk of treatment are too high, but there's a subset of our patients that we will watch, and these tumors can evolve extremely slowly, sometimes for years, without the need of treatment. If the tumor is not too big, we can also do what's called partial nephrectomy. We mentioned before that the kidneys are essential to life. We have only 2, and we certainly want to preserve them. So we can remove only a piece of your kidney rather than the entire kidney. Many years ago, the treatment was to remove the whole kidney, but now we realize that if we can save the kidney, we always prefer that approach. And this can be done many ways. And basically, with your urologist, you're going to decide with him or her what would be the best way. It can do by open surgery, where we make a standard incision, and we go basically, and you have a tumor inside of the kidney. We take that tumor and we repair your kidney. It can be done by laparoscopy. The laparoscopy is we put a camera inside of your abdomen. We put a little hole with a camera, and then we put instrument inside, and we do the same surgery, but from a distance on a camera, looking at a screen. And we can also do nowadays what's called robotic surgery. You can see here who's holding the instrument is a robot. It's called the Da Vinci robot. Many hospitals have that. In the university centers, we all have it. We have it at the MUHC, at the Jewish, at the SHIM. And basically, a surgeon is not standing next to you, actually. We're sitting in a corner, very comfortable, looking in that machine, and we hold the instrument. So it gives us some extra ability compared to the standard laparoscopy, so we can do more complex surgery with that technique, and it gives some more freedom of treatment. The upside is that it allows us to do surgery that we could not do by laparoscopy before, or very few people could. The downside is not available everywhere, and it's obviously anything that's fancy is more expensive, right? So it all goes in the pair. When the tumor is small and we don't want to remove it, there are indications where we can do what's called thermal ablation. We can destroy by heat or by freezing. So this is what we call radiofrequency ablation. There's a little antenna that we can, here's a kidney on a CT scan, and there's a small tumor in the back. It's like an umbrella that we deploy inside of the tumor and we heat it. It's done by the radiologist under anesthesia in the radiology suite, and by doing that, we can destroy the tumor. We can also, instead of heating it, we can also freeze it. So we have a machine where basically we put a little catheter inside of the tumor and we basically create an ice ball, inside of that tumor, and we destroy the tumor by freezing it. It breaks the cells and kills the tumor. It's not good for every tumor. It's good mostly for the small one. The success rate of these techniques are a bit less than the standard surgery. So we reserve that sometime for patients that may be more frail or don't want to undergo standard surgery. So there are very specific indications where ablation can be done. And obviously, if the tumor is bigger, we can do what's called a radical nephrectomy, is that we're going to remove the entire kidney with the tumor inside. And this can be done by open surgery. It can be done by laparoscopy. I would say in Quebec, nobody does that by robotic, mostly because of the cost. And then we can do also sometimes more extensive tumor where we remove the whole kidney. You can have an extension of the kidney cancer inside of the main vein of the body, and sometimes we need to go and remove this type of tumor. The new kid on the block for the treatment of small kidney tumor is radiation. The development in the technology of radiation now allows to deliver radiation in a way that was not possible a few years ago only. And this creates a new tool that we can use for the treatment of small kidney cancer. The long-term follow-up of these patients is not there yet, but it's certainly something that a lot of centers are exploring, and it potentially could be a great extra tool that we can use to help our patients. Now, what predict how patient will do? I think we talk about the stage, we talk about the grade, we talk about the histologic subtype, what type of kidney cancer you have, the size of the tumor, if you have symptoms or no symptoms, and if the cancer is affecting you with weakness, weight loss, and all that. These are all factors that we put in, to help us predict how things will go after. Unfortunately, there's a number of our patients that will present or develop what we call metastasis, meaning that the cancer spread to other organs. And most common is in the lung, but then you can have the liver, you can have the bone, you can have the adrenal gland, the brain. Basically, this type of tumor can go in every organ. And in the follow-up of our patients, we always look for the possibility of spread somewhere so that we can offer treatment to the patients. If unfortunately the cancer has spread, we have other options to offer you. It could be medical option with drugs, or sometimes it could be surgical options. The surgical options are classically limited to small tumor that involve a single organ. So sometimes we have a chance to go and remove those and potentially cure patients from their cancer by removing where it has spread. Or sometimes we can delay the need for the medical treatment that are given classically by the medical oncologist. If you look at the medical treatment, chemotherapy that we all know because it's used in many cancer is not a treatment that has shown efficacy in kidney cancer. It's been tried many times over the years. And basically, it's a treatment that's not an option for our patients. It's just not worth it because of the poor response in this type of patients. For many years, the treatment of kidney cancer was based on the use of immunotherapy. Immunotherapy originally was the use of drugs that we call interferon and interleukin-2. These drugs have been abandoned, and you'll see we have made a whole loop in the treatment of kidney cancer where immunotherapy was the main treatment with very limited success. And we've evolved through a series of new treatments, and now we're coming back into immunotherapy in a more refined way to do that. But basically, it's a type of tumor that responds to the immune changes to boost your immune system to fight against it. But 10 years ago, the immunotherapy was replaced by new drugs that were based on what we call angiogenesis. Basically, kidney cancer is one of the most vascularized cancer. There's a lot of blood vessel forming in these tumors. They're classically very bloody tumors, with all kind of new blood vessel inside. And there are drugs that can dry the formation of these blood vessels. And by doing that, you can basically dry this tumor. Unfortunately, these drugs rarely cure patients, but they can shrink the tumor or they can stop the growth of the tumor. And sometimes you can live with your tumor if you don't have too much side effects with the drug. Even if it's there, as long as it's not growing and giving you a problem, sometimes it's a valuable option until we have more efficacious treatment to offer. And not to go into the type of the drug that are used, but there's a series of these drugs that are available. Probably the most commonly used was sunitinib and pazopanib, but these were the drugs that for the last 10 years were the main treatment for patients with kidney cancer. Now, as I said, the loop has come back where we've heard in the press that improvement in the use of immunotherapy made great success in many types of cancer, and actually kidney cancer is no different than that. These new drugs that make you more responsible to your immune system and block the cancer ability to put a hold on your immune system are demonstrating great efficacy and actually better results than what we obtained before with our standard treatment. So this is a form of treatment that's coming back in our practice very strongly. Actually, immune therapy this year, the two physician researchers that discovered these molecules, there's two molecules, the PDL, PDL1, and the CTL4. One physician from Houston and one from Japan, both were awarded the Nobel Prize this year for this discovery. So it's really something that's meaningful for the treatment of not only kidney cancer, but all cancer in general. Oops. So what we know now about the use of immune treatment is that it can be used alone or in combination. It is also being used now in combination with the medication that I talked to you that works on the angiogenesis or blocking the blood vessel formation. And there's a number of these combinations that are coming in our clinic to be offered to our patients because the study demonstrates that they're more efficacious in very specific group of patients. Can we predict what's going to be the outcome? There's a group that's called the IMDC that developed what we call prognostic factor. They're basically looking at your blood count for the hemoglobin, your calcium, your white blood cells, your platelets, how you feel in general, and when the kidney cancer was found versus the metastasis. And depending on the number of criteria you have, it allows us to predict your likelihood to respond to the treatment and what's going to be the outcome. It also allows us to choose which treatment we feel would be the best for you in all the different choices that we have to offer you. So to conclude, I think there's been a significant improvement at all levels, whether it's localized or advanced kidney cancer. I think our surgery have greatly improved. We can reduce the morbidity associated with them. And also there have been major advances in the treatment of the more advanced kidney cancer where We refine the treatment, make it, I think, easier, and also have better success with it. But I think there's still major improvement that need to be done, because unfortunately, although the drugs we have are have more efficacy, they still cure only of a small subset of our patients, and we're not there yet where majority of the patient we're going to treat, we're going to be able to make this tumor disappear. But at least we have an impact on this, and these are fields that are rapidly moving, and hopefully the next treatment is always more better efficacy than the previous one. So I think I'm going to stop there, and at the end I'll be happy to take any questions you may have on more specific aspect of the management. Thank you.
Thank you, Dr. Tanguay. This is an excellent introduction to the clinical aspects of renal cancer. Our next talk is by Yasser Riadzel-Hosseini from the Genome Center here. We call it Genome Center. I think it's shorter, right? It works still. And he's also assistant professor in the Department of Human Genetics here at McGill. And Yasser will actually dig a little bit more into genes and how identifying the mutations in renal cancer can actually predict outcome of treatment, but also orient treatment as well. Right? So Yasser, it's yours.
So good evening, everyone. Thank you, Thomas, for the introduction. And I am also grateful to Goodman Cancer Research Center and colleagues who organized these events. This is an honor and privilege to be here tonight and being able to share with you some of our work on kidney cancer genomics. And I hope that at the end of the talk, I can deliver this message that there is hope to improve current health care for renal cancer patients. So this photo actually is the Genome Center, McGill Genome Center, located just 2 blocks down in East in the Dr. Penfield Street. That is where my lab is, and that is the place that there is a hub for all genomics facility of McGill. So we are located here, but we are collaborating with colleagues at different institutes in McGill, including Goodman Cancer Research Center, as well as with Dr. Tanguay at MUHC in Glenside. And well, Dr. Tanguay presented a very comprehensive and very detailed overview of clinical management of kidney cancer. What I'm trying actually to do here is just I summarized a bit of this, at least for patients who come with tumor in their kidney. And I would like to actually draw your attentions to those patients who are diagnosed with localized disease. These are patients who suffer from stage 1 to stage 3 tumors. So these tumors are found in kidney, and we think that they are not spread in the body. So they are usually removed by surgery, and but the problem with them is that almost 30 to 40% of patients suffering from these tumors will come back with metastasis or with relapse. Well, staging, as you heard, helped to predict the risk of relapse or metastasis. But as you also heard in the previous talk, many of these patients suffer from stage 1 tumors. These are the small tumors that are localized. They are small in the kidney, and we think that, well, these are good tumors. If we remove them, everything should go well in the future. But we see 30% of these patients, 1/3 of them, will develop metastasis. So the question actually here in research that I would like to discuss with you in a couple of minutes from now on is more to look for new ways that can help current clinical risk stratification algorithm to be able to find those patients that have bad tumors. and improve the follow-up strategy for those patients. So you saw this slide. This cartoon actually showed the procedure after partial nephrectomy. So the tumor is removed by surgery. And what happens to this tumor, it goes, I just check if, yeah, you see the mouse. These tumors undergo pathological examination, which is a microscopic examination. So this is the same thing as you heard, histological examination. By that, a pathologist look at the tumor, actually see the tumor cells, and this test is very critical, it's very important because first it confirms the existence of malignant cells, the existence of tumors, but also will provide information about type of kidney cancer. Is it clear cell subtype? Is it papillary subtype? And you heard that these information are important for clinicians to decide about type of treatment. So the method is very powerful in diagnosis and confirmation. But if we dig into, for example, clear cell subtype only, this microscopic examination cannot really distinguish those tumors that are going to be bad from those tumors that are better. By that, it means those tumors that are aggressive, that may make metastases later on, from those that may just be cured by removing them. So we need to have a more a detailed examination. And by that, what I'd like to discuss with you is that we are after a submicroscopic examination, which can provide higher resolution to the tumors and actually can look into the biology of tumors. And that brings me to the topic of genomic analysis. So I think everyone in the room is familiar with genes. Well, I'm not talking about these genes. I'm talking about these genes here. So, well, I told you that we would like to have a high resolution analysis. We would like to really look inside cells. So, where we look inside cells, we are looking in a specific part of the cell called nucleus, where our genetic material is stored. So these genetic materials are stored, we call this, well, whole of them, we call them genome, and these genetic material are stored on structures called chromosomes. You've may heard about chromosomes. We inherited them from parents. They may be okay in our cells, but when a normal cell turns to a cancerous cells, this genetic material get damaged. And what happens when we look at chromosomes, we see a molecule called DNA where our genes are located. And these genes are located on DNA molecule. What they do, actually they carry information, they carry what we call a code for cells. Cells look at these codes on the genome, in the gene, and use them to produce proteins because they need protein to be functional, to work. For example, they need a protein to be able to produce energy. They need a protein to get rid of the waste that they make. And these proteins are coded by genes, are kept in the cells, and cells use the codes to produce the proteins and work. So you can imagine that it's very important to have the right protein. For example, in a normal cell, a normal gene results in a normal protein that can work for cell, but when this gene is damaged or mutated, what you see here, so either there is no protein produced from that gene, or a protein produced which is not working properly. Either it's doing its work wrongly, or it's doing too much of its work, which is not healthy for cells. So this is what we are looking at. We are looking at tumors that are resected after surgery, after they pass their histological examination, and then we get remaining material of these tumors with patient consent, and we look at these tumors, we dig into the genes to see if these genes are damaged, and if they are damaged, what is the consequence of this damage? So just to tell you, we have 20,000 genes in our cells. Each cell has 20,000 genes. So it's a huge thing to do. It's very, very complicated. I try to a little bit simplify it here. Hopefully you bear with me, but I'm very happy to answer any specific question at the end of the talk. So here I'm showing you a summary of a study where we look at all of these 20,000 genes in individual tumors from 94 individual patients affected only with clear cell subtype of renal cell carcinoma. So what you see here, each column represents one tumor on one patient. And here, these are name of genes that we found them are frequently damaged in these tumors. Starting from top, this is a gene that is more frequently damaged. You can see, when you see this blue or turquoise color, it means that the gene was damaged in this tumor. When you see nothing or you see a gray background, it means that the gene was not damaged in that specific tumor. What you see is that there is no single gene that is damaged in all tumors. But you also can see that there are some tumors that have damage or mutation in VHL gene, but then they may be damaged in another gene or may not be damaged. So there is a huge heterogeneity in the genetic information of tumor cells and the spectrum of the damage to their genome. So now the question is, we know that these damages can affect the function of cells and function of tumor. Can we use these differences at genetic level to distinguish those tumors that are going to be bad from those tumors that are going to be better? Well, bad or worse. So that is the motivation for our research now. And what we did, we picked this list of genes, and then we looked for any correlation or any association between mutation of these genes and outcome, meaning that survival, including overall survival, or disease-free survival, or cancer-specific survival. I'm going to show you a couple of examples here. So what you see here is association analysis between mutation of two genes. BAP1 and PBRM1. These genes we found them quite frequently damaged in the tumors. And here, the tumors are stratified based on the status of these two genes. For example, in red, you see those tumors that had no mutation in these two genes. In blue, you see those that have mutations in BAP1. In green, you see those tumors that had mutation only in PBRM1. And in yellow, you see those tumors that had mutation in both of them. And what happened here, we projected disease-free survival probability, meaning that after surgery, patient doesn't have any tumor or recurrence. Over time, this is time after surgery, and then we looked, what is the probability of having disease-free survival according to this type of mutation spectrum. So if we draw a line at 5 years, 5-year survival here, what you can see, if a patient has no mutation in these two genes, have 85% of probability of having disease-free survival 5 years after surgery, but if tumor of that patient is mutated or damaged in both genes, this probability dropped to 55%. So clearly, these information suggests that, I should say that that is still preliminary observation, although we had a large number of patients contributed to this study, about 500 patients, but we still consider this preliminary because we believe that if we want to have something that works in the clinic, robust and validated, we need to analyze much more samples. But I think it's very promising, showing that genetic information can help to stratify patients based on risk of relapse or metastasis. So I would like to add to this another level of information, which we think is a biological information that can help us for better risk assessment, and that is about role of sex, role of patient sex. And you heard in the previous talk that Dr. Tangi showed you that men are at higher risk to develop kidney cancer than women. So here I'm showing you the rate of kidney cancer incidence. In top, it's lung cancer, and in the bottom is kidney cancer. The black shows the rate of kidney cancer incidence or diagnosis from 1975 to 2015 for both cancers. The blue line shows this only in male, and the green shows the rate only in female. What is very interesting is that over time, from 1975 to 2015, we see that although at 1975, male had higher rate of lung cancer, this difference between male and female dropped. The incidence rate is getting much closer to each other in 2015. So we think that was an environmental factor. For example, a high risk factor for lung cancer is smoking. And I think we all know that men were more smokers. They like to smoke more than women. So, and we think that could be a reason for that. Over time, when they learn that smoking is dangerous, it's a factor that affects health. They start to give up, or the number of male who smoke decreased, and that can underline this decline in the rate of lung cancer in male patients. However, when we look at kidney cancer, same time, we don't see this. So still, men are doing much better than women in getting kidney cancer. So on top of this, we also see another pattern here. When we look at overall survival, this is cancer-specific survival, and we stratify patients, renal cancer patients, based on their sex, we see that the survival probability is lower in men than in women. So these two observations tell us that something should be there which can be explained most probably by biology. Something is in the tumors of male patients that may actually affect the survival to more unfavorable outcome. So based on this, we also included now in our genomic analysis possible role of sex. We ask this question, whether gene mutations can have different prognostic value in male and female patients. And that is what I'm going to show you in the next slide. Here, I'm showing again disease-free survival for patients affected with clear cell renal cell carcinoma for two different genes, TP53, KDM5C. So the blue represent male patients, the red represent female patients. When there is a solid line like this, it means that their tumor didn't have any mutation in the gene. When there are a dashed line like this, it means that their tumor showed mutation in these genes. Again, when we look at 5-year survival after surgery, for TP53, we clearly see that female patients, when they have mutation in their tumor, show a very, very bad survival in comparison to those that don't have mutation. And this difference is much smaller for male patients. For KDM5C is vice versa. Male patients whose tumors show mutation or damage for KDM5C show a poor survival. So I think these examples are quite promising preliminary data suggesting that we should be able to build some new algorithm that can take into account information about genetic background of tumors and sex of patients to help refine current clinical management of patients based on risk stratification. So how we can use it in the clinic, and that is something that we are very closely working with our clinical colleagues, including Dr. Tange, who is actually supervising this type of work with us. So we think that we can introduce genetic testing next to pathology examination to complement pathology examination, because we think that pathology is the core. It has to be there to confirm the diagnosis. But having genetic tests next to pathology can help to have more information for risk assessment. And the question for genetic test here is that whether the tumor has those gene mutations that show bad prognosis based on sex of patients or not. If we see that, yes, there is a mutation in the bad gene, so most probably the patient is at higher risk to come back to the clinic with metastasis or relapse. What can be done? We think that perhaps a more rigorous surveillance and therapy can be recommended for these patients. For example, more frequent imaging tests to detect the metastasis earlier, or even earlier introduction of treatment for the patient to control metastasis. So when there is no mutation in those bad genes, most likely the patient doesn't have this high risk. It's a low risk for recurrence. So can we do something better for this patient? We think that maybe patient can experience a more relaxed life in terms of having not having the need to come to clinic every time to do the test and suffer from side effect of treatments. All of this we think may be important to improve quality of life for patients. So this study actually is trying to help to improve the risk assessment criteria in the clinic for prognosis, for follow-up. But now you've heard about treatment for metastatic patients. So there are treatment opportunities available by targeted therapy, and these days immune therapy. But also you've heard from in the previous talk that not all patients respond to this therapy, even to the immune therapy. So our next question is whether genomic analysis, similar to what we did for risk assessment, can similar genomic analysis help to predict response to treatment? And here I just have one slide to share with you. This is a research not in my lab. It's done in another researcher in the US. And what you see here is association between specific gene mutation and response to immune checkpoint inhibitor. Here you see PD-1. So these are these are tumors from patients affected with clear cell renal cell carcinoma. They all received immune therapy. Those that are shown in blue, those are patients whose tumors had mutation in PBRM1, and those shown in yellow or beige are those that their tumors did not have PBRM1 mutation. And what is quite here obvious is that patients who have mutation, whose tumors have mutation for PBRM1, apparently respond better to the treatment, or their overall survival is better after this treatment. So again, clearly, this shows that there is hope to use genomic to predict what patient may respond to what treatment. And based on that, we would like to build up a kind of a, let's say, algorithm or pattern for personalized medicine or in kidney cancer, where genetic information of tumors can actually inform clinicians what treatment may be best for what patient. For example, if one patient has mutation A, then drug A most likely is going to be more appropriate for this patient. When patient has another mutation, another gene, perhaps drug B. And this is going to be hopefully the future in kidney cancer research. So all the works here have been done by people in my lab, or students, postdoctoral trainees, and I just have the privilege to present the work, but I don't do the job. I would like to acknowledge their work here, also collaborators at McGill Genome Center, as well as in clinical side, Dr. Tange, and also at Goodman Center, as well as other collaborators, international collaborators, and cancer funding provided by cancer agencies. Thank you very much.
Thank you, Yasa. So from the genomics, you've been initiated really carefully into details into this. We're going to go into a little bit more details of the function of genes. In one of the slides by Yasser, you saw VHL has a very frequently mutated gene in renal cell in clear cell carcinoma. But what does it do? What do those genes do actually in cells? What's their purpose? So Arnim Palzi, who's professor in the Goodman Cancer Research Center and Department of Biochemistry, will come and tell you a little bit more about what these molecules actually do in cells and how we can leverage that information to identify cancers that cells heal, and also we use this information to make a bit more sense of what's going on in cancer overall. So Arnim.
Okay. I hope we have some energy left. It's going to get complicated now. So the problem we scientists have is that we have a different language than you guys. And so we sound really complicated and smart, but it's just a language. We're not that smart. We're just average. So you will hear a lot of words and terms that you will not know, and try my best to explain them to you, okay? Okay. So my lab is basically working on the identification of cancer-causing genes. So all these genes you heard about that are involved in cancer. So we are working on identifying them, but once they are identified, the job is not over. Then the job is really, the difficult job is to find out how they work, what they do, and why they cause cancer when they're overactivated or when they're mutated. Okay? And that can be a long fishing expedition, sometimes 10 years, of many different labs around the world that sometimes collaborate or compete. And at the end, you have an idea of how this gene works and in what kind of pathway it is involved in. And once you know that, then other people, like biotech companies or pharma companies, can start to try to target these pathways with drugs and that's called targeted therapy. You saw some examples already, okay? But before you can target, you have to find out what to target. And so that's what we do. Okay, so let's start with a process called angiogenesis. Again, a foreign word, but it means blood vessel formation, so the formation of blood vessels. And it's a normal process that happens in every tissue, and most tissues. And so here is shown kind of a normal blood vessel that has different types of cells. Inside is the blood, and you can then, if necessary, form a new blood vessel or a sprout when it's needed. Okay, when is this needed? It's needed when you have either an injury or a wound, And that usually means that the tissue that is injured or wounded is deprived of oxygen. Why? Because the blood vessels are destroyed and the oxygen cannot go there. Okay, so low oxygen, also there's a fancy word for it, it's called hypoxia. So that's what we use. Normoxia is normal oxygen, hypoxia is low oxygen. So what happens under hypoxia? Hypoxia is somehow sensed. Okay, and it was for the longest time not clear how this works. How is it sensed? But it's clear that when you put cells or tissues under low oxygen, there's a factor called HIF. I'm not going to go into detail what this thing is. It's a factor that goes up in levels, and it's a cancer-causing gene. Okay, and what this factor does, it leads to the production of many other genes and proteins that are then secreted by cells that can lead to the stimulation of blood vessel growth or angiogenesis. Okay, so you get this sprout, and you then have a new blood vessel going into this tissue, and once it goes into this tissue, the tissue is happy because it has now a lot of oxygen as well as nutrients that's supplied by the blood. Before, the tissue was not happy because it was starving, because there was a wound, let's say. And this is all regulated by this factor HIF, which has a lot of downstream targets or downstream proteins it regulates. One of them is called VEGF. And this VEGF is a specific factor to stimulate angiogenesis or growth of blood vessels. Okay. This is just to show you what these vessels look like. So these are control vessels. This is an electron microscopic view of blood vessels in a normal state, and then after 60 hours of a wound or wounding. Okay, you can see this amazing amount of angiogenesis or blood vessel formation that's going on to basically save that tissue after an injury happened. Okay, so why am I telling you this? Because renal cancer is characterized, like the previous speaker said, by a high amount of blood vessels or angiogenesis. And this is kind of a historical presentation because this happened about 20 years ago. Okay, so tumors. So this is shown here. Here's a blood vessel, and you have a tumor. A tumor, when it grows to a certain size, needs basically its own blood vessels because it cannot grow larger unless, so this is shown here, unless it can somehow stimulate the production of its own blood vessels, because it needs oxygen and it needs nutrients to grow larger, and that's shown here. And that's called the angiogenic switch. So some tumors, they stay small, and they do not secrete these factors that can make more blood vessels, and these tumors are usually harmless because they don't grow, they don't get bigger. But once they have the ability to stimulate this blood vessel growth, then they can grow much larger and eventually become aggressive and spread. Okay, so in the next slide, so what we do in the lab is we focus on diseases which are usually pretty rare, which are hereditary, so they run in families. And what's happening in these families is that some of the family members are more prone to tumor formation. So they get tumors much earlier, much more frequent than normal people. And they're called hereditary cancer syndromes. And what usually is the case in these syndromes is that you inherit one bad copy or one mutated copy from one of your parents that also had this disease. And once you have that bad copy, you get cancer much earlier, much more frequently than normal people. And so again here, lots of complicated names, but these are all names for different tumors. So these people with this disease, get tumors in the retina, so in the eye, in the brain, spinal cord, and many other organs, as well as renal cell carcinoma. And what's special about these tumors is that they are hypervascular. So all of these tumors are extremely bloody, full of blood vessels. So the people that get the eye tumors, they often have a hard time seeing because their eye is filled with blood. Most of them are benign tumors, so they don't spread, but they can grow to pretty large sizes and they can compromise function of organs. Okay, and you can see here again, this is the disease, the age of onset, so when do these people get tumors, and the frequency. And you can see for all of these tumors, the age of onset is much earlier than normal people, right? It's in their 30s, sometimes even in their teens, sometimes very early. Like kids already get the eye tumors very, very early. So this is unusual. But you also see that not everybody that has the disease or that has this gene, this bad gene, is getting, for instance, renal cancer. Only 30%. That means there's some people that have a certain genetic makeup or background that are resistant to this tumor, okay? And others get it. And so this is something that's completely unclear and would be very interesting to study, why only some people get these cancers and some don't. Okay, nevertheless, shown here, this is just patients that have these tumors. So this is a brain tumor. Again, it's a complicated name. Hemangioblastoma of the central nervous system, but this is just a large brain tumor that can cause a lot of damage and a lot of symptoms. It doesn't spread, but it's dangerous. It's difficult to operate. Same here in the spinal cord, can cause a lot of damage. The retinal angiomas, they don't do much damage. They're easy to ablate with laser therapy. And then you have the kidney tumors that are usually starting inside a cyst, this little red guy here, and they eventually become quite dangerous. So what these poor people, these patients, they get in their lifetime up to 20 of those, and sometimes up to 100 of those. So they're constantly being screened and monitored and operated. Since the discovery of this gene and modern MRI and things like that, these people live relatively long lives, but it's not a great life because they're constantly in the hospital. Okay, so what are these cancer-causing genes? There's two types. One are called oncogenes, or on top here, or you can also say overactivity mutation genes or gain-of-function genes. What is meant is that in every cell you have two copies of each gene, one from daddy and one from mom. And sometimes you inherit or you get a mutation in one gene, and this gene is directly linked to cell proliferation, meaning to cell growth. So when this gene is activated, cells grow and build a tumor. When this gene is inhibited, nothing happens. When you get a mutation in this gene that leads to a permanent gain of function, then this gene is always on, and you get cell proliferation. And eventually you get a tumor. Probably only a benign tumor, because you need other mutations for the tumor to get more aggressive. Okay, so this is a dominant mutation, and then you have these underactivity mutations, or loss of function genes, or what we call them also tumor suppressor genes. These are genes that block tumor growth or block cell proliferation. So this is like a gas pedal in a car, and this is like a brake. And what happens with these genes is that you have, again, two copies. And if you get a mutation on one, that inactivates this gene. So in this case, it's a gain of function, an activation of the gene. In this case, it's a loss of function, an inactivation. Usually what happens if you lose one of these copies, nothing, because you still have a good one. But if you lose both, you have no more activity. That means your brake is no longer working and the tumor can grow. Now the people with the VHL disease, they are born like this. In every cell of their body, they have a mutation, an inactivating mutation in the VHL tumor suppressor gene. So that means the chance of having another mutation is much higher than in normal people that look like this, because they have two healthy copies. And the chance of losing those two healthy copies is much lower than for these people. That's why they get tumors much earlier. Okay. So this was all known. The disease was discovered maybe 100 and something years ago. But the gene was only discovered in 1993. And you can see how many people were involved in this. It took about 10 years of hard work. That was at the National Institutes of Health in Bethesda. About 30-something people worked on this. Nowadays, this would go much faster because we have much better techniques to do this. But at this time, it was much slower. Anyway, so these people found the gene that is responsible for this disease. And they also found that when they looked at hundreds of different patients from different families, that all have this disease, but they're all different. They all come from different countries, and that they have different mutations. So each family has a different mutation. But they all cause the same disease, okay, these mutations, each one of them. So they all must be inactivating somehow this gene. Now, this is all very nice, but how do we go from this knowledge to the treatment? We need to understand what this gene does in normal cells. Why do we have it? What does it do? And why, when we lose it, we get a tumor? Okay, so this is just to show you again what's happening in, for instance, a renal tubular epithelial cell. So these are the cells inside of your kidney that filter the blood, and they form a tube. And what happens here, and this is where the kidney cancer starts, okay, in these cells. And so normal people have 2 copies of VHL, and they have to lose both copies to basically lose the function of this gene, which then develops into a renal cyst, which is kind of an overgrowth, or we would call that a benign tumor. It's not terribly dangerous. And you would then need another mutation in another gene, shown in red here, to actually get something that looks more like a renal cell carcinoma or a tumor. So again, 1 gene is not enough. You need about 10 on average to get a full-blown cancer that will metastasize and be extremely aggressive. Okay, and the people with the disease, they're born like this. Okay, so they only have one good copy. That means their frequency of developing tumors is higher. Okay. So now, long story short, it took about 6 to 7 years, several different labs, including mine, that worked on this, and they've tried all kinds of different things. One thing that worked was to look for associated proteins. So every protein in the cell is usually not alone. It acts in concert in a complex, okay? It forms a complex with other proteins. There's almost no proteins that work alone. And the idea is, if you don't know what your protein of interest does, you'd find out what it hangs out with or what it forms a complex with. And if these proteins that it forms a complex with are already characterized, then you can kind of figure out what your protein of interest does. And so that's what we did. This looks like you will not understand this, but take-home message is this complex, here's VHL, looks very similar to this complex, okay? This complex is isolated from a yeast cell, which is a single cell, kind of a simple organism you would call compared to a human being, right? But both of these cells have this protein complex. And the people in the yeast cell, they figured out what this thing does. And so we thought, okay, maybe this protein does the same thing, but in mammalian cells. And what does this protein do, or this complex? It targets certain target proteins for degradation, or digestion, or destruction. So this protein binds to a target, and this target is then modified, and once it's modified, it gets destroyed. That means in the presence of this complex, your target protein is destroyed, is not present. In the absence of this complex, it's there. Okay? That's kind of a simple description what's happening. So you would expect that in patients that have no functional VHL, your target protein would accumulate and be there in very high amounts. Whereas in normal cells, you can't see this guy. And this is exactly what's happening. What is this target? This target is this factor HIF I told you before. And this factor HIF is involved in driving gene expression and proteins like these here, VEGF, PDGF, TGF-alpha, erythropoietin, that are involved in blood vessel formation, but also in tumor growth. And when you have functional VHL, this gene is constantly destroyed, meaning these things are not expressed and you don't get tumors. But when you have non-functional VHL, and that's shown better here, this factor goes up, it's highly expressed. It leads to expression of all these different genes, but many more. And you can now target these genes with different drugs. And these are the drugs that the first speaker talked about that are now lead to a response in kidney cancer for the first time. So this is the targeted therapy that was then was starting to be used 10 years ago. This was all based on this research. Now the frustrating thing is that there was a response, yes, but it didn't cure people. People just lived longer with their tumors. But that's already a start. Of course, a better target would perhaps be this guy, because here you have the general, right? These are just the soldiers, and there's many of them. But this guy is the key factor. So far, there haven't been very good drugs against this protein, okay? But people are working on that. Okay, now this was the past, and what we're working on now in the lab is another syndrome, but I'm going fast, so don't worry. A few more slides. This syndrome is also extremely rare. It's even rarer than the von Hippel-Lindau syndrome. It's called the bird-hog-DeBay syndrome. It was discovered in Canada about 100 years ago by 3 Canadian physicians. And what they saw is that the patients that have this syndrome, they develop benign tumors in the face, or upper torso. They're called folliculomas. They're hair follicle tumors. They're not dangerous. They're just don't look nice. But also these people develop kidney tumors, okay, in both kidneys. And what's interesting is they develop one type of kidney tumors that is quite benign, but they also, in the same patients, can develop all other types of kidney tumors. So it looks like that the gene that's responsible for this disease might be some kind of, or the pathway might be some kind of a general pathway in kidney cancer, which I thought was interesting. So the people with this disease have an inactivating mutation in a tumor suppressor gene called folliculin, okay, FLCN. And they develop all kinds of different tumors, melanoma, hair follicle tumors, renal and colon cancer. So very similar to the story I told you before, but a different gene and a different pathway. And the gene was cloned in 2002, and then we started working on it, I think, in 2004, and we and others found that folliculin interacts with protein, binds to a protein called AMPK. Now, I know you all know what AMPK does. So what is AMPK? AMPK is a protein that can sense the levels of energy in a cell or the levels of nutrients. So if you deprive a cell from energy or nutrients, this protein is upregulated. Okay? And what does it do? It basically inhibits processes in the cell that cost energy, so which is called anabolism. So it inhibits those, and it stimulates processes that generate energy so that the cell can survive. And one of the energy-generating processes is called autophagy. Again, a fancy word. So if you don't know Greek, you don't know what it means. So it's self-eating. So this is kind of a built-in cellular recycling pathway, where the cell, when it feels there's no nutrients around, and this goes all the way down to yeast cells. So yeast cells, their food is glucose, right? They only use sugar to make either, yeah. And so when they run out of sugar, they turn on this gene, turn on this process, it's called autophagy, it's called self-eating. That means that they digest damaged proteins in the cell. So every protein has a certain half-life. And at one point, it's over, it's damaged, and then this process will digest this protein into amino acids, which they can then serve as building blocks for new proteins, but also to generate energy, ATP. And so basically what happens if there's energy stress, this thing gets induced, which induces this autophagy process. You see immediately after 5 minutes an increase in energy levels, ATP levels. It means the cell is happy again and has energy. This is a short-term process, of course. Long-term processes are like digestion of lipids, fat, or carbohydrate stores like glycogen. But this is a very short-term survival process. Anyways, why am I telling you this? Because we figured out then about 10 years later, using worms as model organisms as well as human cells, that folliculin is at this position here. And folliculin, this is the tumor suppressor that's responsible for this disease, is blocking the activity of this guy. And what happens is when you have folliculin knockout or deletions in cells or in these small organisms, these worms, they become very resistant to any kind of energy stress. So that means they don't need nutrients. They can survive without food for a while. Makes them amazingly adaptable. Why? Because they have constant activation of AMPK and constant activation of autophagy. And you can imagine that this pathway can also be beneficial for any kind of tumor cell that wants to grow and a tumor that wants to get bigger, because these tumors need a vast amount of energy. And so if this process is turned on all the time, then basically the tumor is happy. And so again, another 5 papers later, or another 5 years of work, we came up with this complicated model. So this is kind of the pathway that we discovered with not all the players, but a lot of the important players. I'm not going to go into detail. But all of this leads to increased energy, increased building blocks. We call that the cells have a metabolic advantage because they can survive all kinds of stresses, which leads to tumor progression, but also what we found recently to drug resistance. So when you have this complicated picture, you want to eventually find something here that you can target with a drug to target eventually the tumors. This guy here, TFAB-TFE3, there's no drugs available. There's no drugs for this guy, not for this one. There's some for here, and there's one for this AMPK. So we tried that to start. And this is just recent work from Liana, a graduate student in my lab. And so what she did is she treated cancer cells with chemotherapy. And as you have heard, especially renal cancer cells, they're resistant to chemotherapy. They don't react. And what happens to normal cancer cells is they sometimes already have an overactivation of this pathway, so this folliculin AMPK TFE3 pathway, which leads to increased autophagy and drug resistance. And so even when you add chemotherapy, these cells survive because they have this pathway turned on. Now, if you use an inhibitor of AMPK, we call this AMPKI, you block this pathway, and now your cancer cells become sensitive to the chemotherapy because they can't survive any longer because they have no energy. And then they die. And so that was just a recent result, and we'll see how far we go. We had tested this in breast cancer cells, and we will test it also in renal cancer cells and maybe also pancreatic other cancers. But this is kind of the basic research we do in the lab in the Goodman Cancer Center. And these are the people that were involved. So this is the people in my lab, some former people, some new people, and these are all the collaborators around the world. And this is funding. So we have grants from many different places for this work. Thank you very much.
Thank you, Arnim. So I told you we'd dig deeper, and we did. The next portion of the lecture is always quite special to me. It's a testimony, and the reason for that is because beyond the science, above and beyond the science, there's always the people. There's always the human stories. And it doesn't really matter how long and how many papers or complicated terms we align here. What really speaks to you and speaks to me is the human stories. So I'm actually quite grateful that we have Hélène Veilleux tonight to actually share her personal story. Thank you, Hélène, for coming. Different format now. So this is a bit different format. It's going to be more like a discussion. I'm just an enabler here. It's all your story. It's an amazing story that you have to tell. So thank you again for being here. Your story, I believe, started with the wrong diagnostic or the wrong subtype. Can you tell us a little bit about how you were diagnosed and what was the turning point from the original diagnostic?
Okay. Good evening, everyone. I was diagnosed at the age of 42, 10 and a half years ago. Like we saw with Dr. Tanguay, first sign was I had blood in my urine, then became a big, major pain. I always say that it was worse than giving birth to my two sons, and I had them naturally. So I went to the hospital. Nurses at triage said, it's probably kidney stones. Maybe you could wait and go to your clinic tomorrow morning. She said to me, maybe sometimes with kidney stones, something that helps is take a warm bath. So I have to tell you that it was December 30th. So I came back home, took her advice, take a very nice warm bath, and the pain grew and was awful. The next morning, I went to my neighborhood clinic, and then I was prescribed to go and do an ultrasound. And so less than 24 hours after my first signs, I was diagnosed with a 9 centimeters on my right kidney. So I was in the hospital, met with, it was the original hospital, met with the urologist that said, you're next in line for, and I had surgery, radical nephrectomy, less than a couple of weeks after, 3 weeks after. At that time, when the results came back, they said to me that it was a clear cell renal carcinoma. And I was like very young, 42, good shape. I was training almost at that time, 3 times a week. I was always been athletic. And the urologist said to me, you're in good shape. I'm sure in 10 years, after the regular follow-up, I won't see you anymore. I'm sure you'll have a very good life. So that's what I did. Went back to my life, and 4 years later, on our follow-up scan, showed up that there was it came back with a few a recurrency. I was lucky enough that my urologist met Dr. Tanguay a few weeks before on a conference, and he decided to transfer me to Dr. Tanguay. And so I've met Dr. Tanguay a few weeks after, and we did another biopsy of these new with the Mets, and it came back that it was a non-clear chromophobe renal cancer. I was explained that at the time, in 2008, 2009, the techniques were different than in 2013, and it's probably that's why the
Identification of subtype.
Exactly. So went on some targeted therapy before doing a resection of the little lesions I had at the time.
It was key at that moment, I remember from your story, that you were always part of the process and the decision-making as to which intervention to do. And can you tell us a little bit about how important it is for a patient to be part of the decision process for the treatment?
When I was diagnosed after 4 years with the relapse, my world fell apart, and I was trying to get information. Went on website and found some website that were very old studies, and then got through and find the Kidney Cancer Canada website. On the website, I was lucky to find some very important questions to ask to your doctor. So my first meeting with Dr. Tanguay had all my questions prepared. And for me, I had the impression that with him, we made a team. He explained me what was happening, but I also felt that there was always plan A, plan B, plan C. Like he said, sometimes the thing what you could do is to, let's say, let's observe and see what's going to be it's going to be like in 3 months on the next scan. For me, like I say, I'm quite active, and I was an impatient patient, so I wanted to do what I felt I wanted it over with, and I didn't want these intrusion in my body, so I wanted gone and go back to my regular life. So I decided to go with the therapy than the surgery. So what the targeted therapy did for 4 months prior to surgery, everything all the lesion went down. So it was easier for him to do the surgery after.
So that's all essentially your approach, and together have been since then, right? The management of the disease.
Yes, and ever since 2013, meeting him, always it's been 6 years, almost 6 years and a half now. Always felt with him and the team there with my oncologist. I always feel that I have a power, and I'm proud to say that I'm well informed and by them, and I always have a choice, and I always feel that I'm in good hands with them.
Is that what underlined your commitment to Kidney Cancer Canada to advocate and facilitate access to information?
Well, I felt that I really had good information when I went on the site in 2012. Then I registered and I received some email with information, and then I went to a meeting. It was in Montreal at Hôpital Notre-Dame Hospital at the time. And then I became involved as a volunteer, and I've been a board member for a year and a half now. And for me, it's very important. We offer peer support. We offer, for us, it's very important that patients, caregivers are well informed, have received the best treatment. And every information that you're going to see on the website, we have a medical advisory board. So it's not anything and any kind of information. It's all revised by doctors and clinician, pharmacists too. So every information that you see You know, you can be sure.
Was proved and high quality
Yeah.
is reliable.
You know, you won't find some. Anyway, I would.
You're the wrong sort of information.
Exactly.
One of your important message that came about was, so yeah, just in passant, there's actually a couple of those pamphlets in the back where, if you're curious about Kidney Cancer Canada, their resources, they're accessible on the table back there. One of your important messages was the importance of including the rarer subtypes of kidney cancer in the clinical tab. So we spent the whole evening talking about essentially more precise therapies, personalized medicine, but you mentioned the importance to include the rarer forms, and which are usually excluded from the clinical trials, right? Can you tell us a bit about that?
Yes, I will tell you that you've seen 75% of renal carcinoma are a rare clear cell, and because I have a non-clear cell, I would say that I got refused to go on clinical trials and try these new drugs because I was a non-clear cell, so patient. It's kind of frustrating because you want to have access to these new drugs, and sometimes just because of the subtitle I'm in, I'm not able to, and I got refused to these very good therapies that are coming up. So this is a point of, for me as a patient, to tell researchers and pharma could you please, think about us and our rare cases, and is it possible that, for sure, I understand that farmers want these drugs to be accepted, and you want to have the best results, but would it be possible to have a little wing in
At least include a bit of the other subtypes.
Include us, please. So,
All right, so that's an important message. Your testimony tonight is one of hope, but also one of engagement and one of advocacy as well. So thank you very much, Hélène, for being here. And yeah, I think we can applaud you again.
Thank you.
Thanks, Hélène. So next step in our evening is actually the forum itself. So you receive white cards. You have plenty of time to write your questions during the evening. There will be two volunteers that will grab your questions and bring them in the front. You can take maybe 5 minutes if you're thinking about a question to write them down. During that time, the scientists who actually took part to the scientific presentation, but also Hélène will be part of the panel as well to ask your questions, whether it's for the clinical, the science, the genes, the genomics, but also the advocacy for patients or so a bit of the personal experience here with renal cancer in Canada. And they will be sitting here and at your own moment. If you want to come, you're welcome to, right? Okay, so Hélène is here. And Arnim. Yasser, Simon, Hélène, and Arnim. There you go. If you can turn them off, right? I think I'll just keep one. It's fine. You have some? Very good. So while I ask those questions, if some more pop in your mind, don't hesitate to write them down. I didn't mention that at the beginning, but if you want to ask your questions in French, you're more than welcome. I will answer in French as well. We will answer in French, and if we can't answer in French, my panelists will answer in English, and I will translate. So there's no problem there. Okay. Please have a seat. Make yourself comfortable. We have really interesting questions. Every time with those forums, sometimes you get things that are really deep, science. Sometimes you get curveballs. I've heard questions about robots and lasers. It's all over the place. It's really fascinating. But I would say the vast majority are excellent questions, so don't be shy. Ask away. A question here, and whoever wants to answer, grab. Sometimes we can take multiple turns. Can renal cysts become cancerous?
So the answer to that is yes, but the vast majority of renal cysts will never become cancer. And on the X-ray, we have ways to determine which cyst is at risk, and those we follow. patients are coming every year or every 2 years to have regular X-ray. The standard, what we call simple cyst, these don't have a risk to become cancer, and we don't follow them because actually probably 30 to 40% of adults have this kind of cyst. So imagine if we were following them all, a huge number of tests that are done unnecessarily. So we don't follow those.
Very good. You have more cards for me? Thank you. All right. So this one's about essentially, it's about gene therapy. In the current gene technology, are we able to manipulate the mutated genes responsible for kidney cancer, for example, and replace them with healthy genes? Anybody wants to talk about CRISPR?
Right now, no.
At the moment,
At the moment, no, but maybe in the future there are some new things coming up, some new techniques, technologies. So
gene therapy, though, has been tried, right?
It has been tried,
It's been
yeah.
visited before. We just didn't have the right tools, I believe.
But the tools were bad. Now with CRISPR, they're better tools.
Yeah.
So
So what we're talking about with CRISPR is genome engineering. They're actually molecular scissors that allow you to modify specific base pairs or sites in the DNA and restore the original gene. You can either inactivate an oncogene, the bad genes that were introduced, or you can, in some cases, repair the damaged gene. So those technologies are in the labs. We can do it in mouse. And there are actually some trials, some attempts of that in some types of cancer that are actually ongoing. This is the future. It's now. And by the way, this was discovered in phages of bacteria. So it's just telling you how model organisms sometimes provide the answers to that are unexpected, a bit in line with the yeast comment by Arnim. So a technical question, I think it's for you, Simon. Do you repeat the staging if the MET is discovered with relapse? Do you repeat the staging every time?
So, when you had kidney cancer, you're going to be followed, basically for a long number of years. And when we repeat the X-rays, basically we redo a staging, if you want. So we're trying to discover if something is happening. And the hope of all these tests is that we catch them early so that we can treat them more effectively. We can treat them sometime with surgery, with radiation, or go on medical treatment earlier. So yes, we repeat the staging all the time by doing the test.
Mm-hmm. Another one is where does the blood test stand in diagnosis, prognosis? Blood tests, are they useful in case of renal cancer?
So that's something that we often, patients tell us is, I see my doctor, regularly have blood tests. How come this was not found? And actually, very often the regular blood tests are totally normal. There's no blood test specific for kidney cancer. We have some for prostate cancer, for example, in our practice that we use to screen for prostate cancer. We don't have that for kidney cancer. So sometimes we find changes in the blood tests that are in direct reflection of problem happening, but they're very general, and sometimes it allows us to dig a bit deeper and try to find why this happened, and that's how you can find, kidney cancer or other form of cancer at that time.
Is there a relationship with the prevalence of kidney stones and kidney cancer?
No. No relationship.
No relationship. Do pediatric cancer behave differently than adult cancer?
If we talk about kidney cancer, the form of kidney cancer we discuss tonight, they exist in the pediatric population, but they're very rare. I think for me, the youngest girl I've seen was 10, and then it recurred to lymph nodes, and she had multiple surgery. So they do exist in pediatric age group, but most of the time it's a different form of kidney cancer that they're specific to pediatric population, and then as we grow up, these kind of tumors disappear. They don't develop or rarely in adults.
I see. This one is for Yasser, I believe. If there are gender differences, have we looked at the role of sex hormones?
Well, that is a very good question, and we didn't look ourselves. That is something we are currently planning to do. But there have been some studies, I think, at least at the clinical studies, where a role of sex hormones have been studied in population level by dividing. Well, it's indirect, but I think they divided the population of patients to those that are married or unmarried, and then they assume that sex hormones should be more active. And it's been shown that there have been some roles for sex hormones in outcome, but we have not looked at it ourselves. This is something that we would like to combine with our genetic study.
I see. The cause of renal cancer, is it due to the environmental factor, food, for example? Why did it increase in 20 years? I guess it's to your talk speaking. Why did it increase since the 20 years? Do you think it's environmental or?
Oh, I think the question is that the increase that we see in the incidence rate, right?
That's right.
So I think, Simon, you already, I think, referred to that we don't know exactly what is the reason for the increase, but I think by the technology advancement that we have, especially with imaging system, now we have better chance of diagnosing the cancer, maybe because you mentioned that some of these tumors are there, but nothing happened, they stay long. And maybe there were some patients that have had the tumors, but since they didn't behave bad, maybe we just didn't diagnose them. But now we just detect them accidentally because they come to clinic for checkup. Of course, there might be, and I think there are some biological reason. Human life is, the style is changing, and we realize that most likely we have more stressful life, and we know cancer is something that is a complex disorder. Many factors contribute to that.
I see. I have a question for you, Hélène. We've heard that in recent years, we've heard that there's a big difference between the outcome of treatment depending on whether you're far in regions or if you're in cities. There's actually a couple of studies showing that. Do you have a feeling for whether patients have a greater empowerment or more input in the treatment, whether without naming a place, for example, or an hospital? Do you see that there's a greater involvement of patients in decision-making depending on where you are treated?
Good question. I would say that it's one of our goals that every patient, even if they're in a very remote region, that will have access and the best treatment of care that they're, even if, compared to a university hospital.
I see.
That's what the main goals, that, every patient should be treated equally.
Right,
but
so
of course, we see a difference.
It's a mission, but there is, okay, I see. Thank
in
you.
reality, is still different. Sometimes.
All right. Question here about sex differences. I guess, no, actually more general. It could be either Simon or yes, sir. If females have frequent urinary tract infections and low back pain, is this a sign to be worried about renal cancer?
No, the infection and kidney cancer have no relationship. The back pain, there's many causes of back pain. Obviously, kidney cancer can do that, but there's everybody has back pain, so there's many other causes. But certainly, persistent pain, that is new and persistent, a bit like blood in the urine. I think sometimes you need to look into it, to make sure that you rule out the important problems.
Is there a link between kidney cancer and bladder cancer, genomically or clinically?
No, they're unrelated. There is a form of a cancer that can occur inside of the kidney that is the same type as what we find in bladder cancer. The type of cancer we discussed tonight comes from the kidney tissue, the one that filters the blood. But once the urine is formed, it drops in what we call the collecting system. That's the centerpiece inside of the kidney where the urine is collected, and then it drains into our bladder. That part inside of the kidney, the cells that line that are the same cells that we find in the bladder. So you can have bladder cancer type of tumor inside of that part of the kidney. So yes, in that regard.
I see. What is the success of treatment when renal cancer has metastasized to the lung versus the liver? Is there a difference depending on where the metastasis is, whether the treatment will respond or not?
So you can have good response everywhere, but there are organs where I would say the challenge is bigger. You know, liver is an organ that sometimes is more difficult to treat, not always. Brain, for example, it's an organ that can be more difficult to treat. The lung is the most common place where kidney cancer will spread. So it's certainly one where we have, I would say, more experience and more patients that we have assessed, you know, the result of it. And it seems to be one of the sites that is, I would say, more favorable, often more favorable to allow surgery to remove the tumor and also for the response to the treatment.
So a question here about metastasis. So if metastases happen early, if they're detected early and they happen early in the progression of the disease, does it change the increase or decrease the overall survival rate?
So that's a very good question. So we know in all of the study, and at the end I showed you that 6, square, that predict the outcome of patients. We know that if the metastasis is present at the time where the kidney cancer is found, it's not as good as if many years have gone by before the cancer came back. And actually, when your cancer come back, let's say 3, 4, 5 years after, that means that these cells were there from the beginning. And for some reason, they stayed quiet. And so there's something in you or in the form of cancer that's more favorable. So I think it pretends for a better behavior of the cancer than when it happens right away.
I see. How do benign cysts turn cancerous? I guess it's a long answer question.
So it's a bit like the first question we had. Those that are benign on X-ray, normally they don't turn cancerous, and we don't follow them actually.
I see.
Actually, very often I don't even tell patients they have cysts in their kidney when they're benign cysts. Just because they're, like I said, 30–40% of adults have them.
So the answer is no, not much, right? Are there any research protocols available in Montreal for non-metastatic renal cancer? If so, what's the rationale?
For non-metastatic kidney cancer, so there are protocols that are done, I would say, for the prevention of reoccurrence of cancer. We had a study that just closed, actually, where patients that you remove their kidney, and when you look at the pathology, you realize that they have many criteria that make them at high risk to see that tumor come back in the future. So all of the new drugs that come on the market, they're all tested to see could they help prevent reoccurrence of cancer. If you or your family member or friends had, for example, breast cancer, colon cancer, after surgery, often the patients receive treatment as a prevention. So far for kidney cancer, every drug that was tested did not demonstrate a benefit. But we've had studies to try to test the new drug in that context. So there's always some study that come and go in most of the university centers.
For as long as we can have access to them, right?
That's correct.
So some of the questions I couldn't read, or if I haven't asked your favorite question, by all means come afterwards. I have one last question I'll ask, and it's something that I always ask or get to ask more and more. We've learned about the molecular limits, the frontiers of research, the integration of genomics, and we've also learned that it changes pretty fast recently with science to clinic. So how long does it take for a new discovery to be applied to clinic, and to what extent are our clinicians actually staying abreast of the latest findings? How fast and how can we accelerate this transition from knowledge to an application in the clinic?
I think it's always too long. That the answer is always too long. Okay, it can take decades actually. It's people's career, that go for a new drug development and before it goes to the clinic. And very often you have great ideas that can not be recognized. We have one, for example, in prostate cancer, of a drug that revolutionized the treatment of prostate cancer that stayed on the shelf in a lab in UK for years. And someone realized it and bought it and put it to the market, and this drug has been extremely successful. So I think the best way to make progress is to make sure that everybody works together, all of the clinicians and scientists. And I would say that in kidney cancer, in Canada, we're very fortunate because we have a research network where everybody works together in a non-competitive way. And we meet every year, twice a year. The researchers are part of this. Kidney Cancer Canada is a part of this in our forum. They participate actively. We have a registry to understand the behavior of the tumor of our patients. And I think that's how we move the field forward, actually.
Collaboration.
What
a beautiful way to end our public forum. Thank you very much for being here. Thanks to the forum speakers. Thank you very much for your answers, very much. And this is our last session of the year, of the 2018-19 session. We'll see you, I hope, somewhere in the fall with new public forums. So these, the presentations, including the question and answer session, will be posted on our website. The link is actually on, you probably are already aware of it. You can find it on the Goodman Cancer Research Center webpage, and you can also write to us, and we can actually channel some of your questions if you write as well. So on this, I wish you a great night, and thank you for coming.